Now we're going to start to talk about chapter 8, which is the restoring range of motion and improving the flexibility. Now I want you to think about some of the activities that you do on a daily basis. Okay, so when you get out of bed in the morning, what are some of the first things you would do? Maybe you go wash your face, take a shower, or change your clothes, brush your teeth, or maybe make some coffee. But everything we do on a daily basis requires actually a lot of motions in multiple joints. Okay, thinking about how you're going to hop on a car and drive to campus, or maybe go up and down stairs. It is very important that we have a functioning tissue and joints that is ability to fully move without feeling restricted. So the restricted range of motion and restoring range of motion is some of the first thing that we will typically do, especially with the post-op patient who started to have some limited range of motion, maybe because of the long period of immobilization. In order for you to have a normal motion in the joint, what you're going to have is you have to have two different kinds of motions. Okay, one of them is known as osteokinematics or osteokinematic motions, and those are the big motion that you would typically see, you would typically think of when I say motion. So for example, looking at a knee joint, you have ability to flex and extend that knee joint. It's nice and big and it's very visible. It's observable by anybody. That is an example of osteokinematics. At the same time, when you are flexing and extending that knee, what's happening inside of that joint is you also have very small, teeny tiny amount of motion that you really cannot observe. It's so small that you can't really see it, but it's still happening in the joint. Good example of that is rolling motion, spinning and sliding, as maybe you can see a little bit in the picture. Now we're going to talk a lot more about this osteokinematics when we talk about joint moves in the lecture day. But please remember that we have big motion and small teeny tiny motion that you can't really see happening at the same time in order for you to have full range of motion. A little bit of terminology just so you would know. Difference between hypomobility, hypermobility, that should be pretty obvious. Hypo means too low, hyper means too much. Okay, so we're just simply talking about limited range of motion versus excessive mobility. Okay, do not get hypermobility confused with instability. Instability, yes, you're gonna have hypermobility, but what you also don't have is ability to fully control that muscle, that joint. Okay, so you have to have hypermobility in order for you to have instability, but you can potentially have hypermobility but no instability. Okay, maybe you have excessive motion in that joint, but you do have full control of the joint, that it's not very unstable. Yeah, that's very possible. Flexibility is something good. It's ability to move a joint throughout the range of motion. Contracture is a condition where you have some kind of soft tissue started to become very shortened because of the excessive scar tissue, or the actual fibers started to contract more and more. So now you started to feel a lot of restriction in range of motion, okay, because of the soft tissue shortening. And then here's an interesting example. Prolonged immobilization can result in adaptive shortening of a muscle or a ligament of the tendon or maybe joint capsule. So if you happen to be in the shoulder sling for a very long time, which your elbow is going to be flexed at about maybe 90 degrees or a little bit more, what you're gonna maybe be able to see in this picture is your biceps brachii is stuck in a shortened position and your triceps is going to get stretched out in this position. Okay, imagine you be in this shoulder sling for a week, and what's going to happen to your biceps and what's going to happen to your triceps. Now triceps is going to be okay because it's stuck in a little bit stretched position, so it's not going to lose its length, so you're probably still going to have a nice flexibility there. But problem here is the biceps biceps brachii. It's stuck in a shortened position for a very long period of time. Okay, let's say for a week. It's going to go through the period of adaptive shortening because the fiber was stuck in a shortened position for a long time. It starts to lose ability to fully get stretched out. Okay, maybe you start to experience a little bit of a shortening of the soft tissue, and it's going to take some time for you to gain that range of motion back. In order for us to measure range of motion, there are many different tools that's out there that we typically use. The classic one is a goniometer, as you can see in this picture. You do have very specialized goniometer, maybe for example to measure finger or toe flexions like that, but idea is the same. Sometimes you can even use a tape measure to measure range of motion. For example, in this picture, the clinician is measuring the degree of spinal extension, okay, both cervical and the lumbar spine segment at the same time. So what they're doing is they're going to measure the distance between maybe C7 through maybe L4 or 5 or something like that, and ask them to extend the back, and then going to measure the distance again, and the loss of the distance is going to get recorded as the range of motion. You also have something known as inclinometer. You have this bubble inside that would measure what's vertical, and you're going to use that to get specific angle. You also have so many different phone apps these days that you can potentially use to measure range of motion, which is pretty handy and fantastic. Maybe those apps might be a little bit cheaper than you buying multiple goniometers. You have your phone right there with you all the time, so it's pretty convenient as well. You can maybe do it on the field. So depending on the apps that you're looking at, I don't know if you ever had a time to say look for anything, and I'm pretty sure prices are going to be very different from app to app, but some of the phone app will allow you to take a picture of the patient. You can place certain dots using a specific landmark, and then they are going to measure the angle for you. Or maybe you can almost use that as the inclinometer, measure this angle and that angle, and again it's going to do the math for you and then get the range of motion. Similar thing, this is actually an inclinometer app to measure cervical lateral flexion. Okay, so the great thing about these phone apps is it's very handy, it's right there for you. Maybe it's a little even easier for you to use. It's very convenient, but at the same time you have to be very careful because those phone apps must be fully validated for you to use it. Okay, because you never know if those apps are really accurate or not. Okay, so a lot of researches will have to be done ahead of time to fully validate those apps. Okay, so you can use it casually, but in order for you to really fully record everything in the medical document, I would say try to go with the more validated tools instead of using some of the phone apps that's just coming out. Okay, it just has to go through some of the studies to be again fully validated. But do not forget to obtain, these range of motion measurements are only, remember we talked about the clinician-based outcome measures. Okay, that's actually that. We measure it, we validate it, but what about the patient? So do not forget to obtain the patient's perspectives. Do they think they have enough range of motion to perform, for example, play sports, take shower, twist the doorknob, getting in and out of the tub, maybe going up and down stairs, or anything that they do on a daily basis? Do they have enough range of motion to perform all those things? It's always nice for you to use patient-based outcome measures, some kind of questionnaire, okay, to get the sense of it. Or it's always easy, simple for you to ask those questions to the patient. Hey, do you think you have enough range of motion to, say, sleep at night? Or is there anything that you're struggling right now because of the restriction of range of motion? If they happen to address that during your conversation, then you need to make sure that you're going to work towards that goal. Okay, so they have enough range of motion to perform whatever the task that they would like to perform. Okay, don't be looking at just the numbers of the goniometer and then just be happy by yourself. Make sure that they're happy, okay, at the same time. There are two different kinds of range of motion that we could measure and we could use and we could incorporate during the rehab process. Passive range of motion is the one that clinician is going to stabilize the patient's, say, body and going to move the body part for them, and the patient is going to remain relaxed. What we are looking at here mainly is how tissue is flexible and they have ability to extend, as well as the joint's normal orthokinematics. Do you have those little teeny tiny motions in the joint for it to allow the gross motor movement? Okay. Active range of motion, this is the one that patient is going to move him or herself very actively, and we're not going to assist them. On top of the tissue extensibility and normal orthokinematics, what you can measure in addition to those is the muscular strength, because he or she is moving by themselves, and the neuromuscular control. Okay, so on top of these two things, you can add some additional measurement, okay, by having them perform active range of motion. So those will be actually considered as indications when they have actually some restriction in soft tissue or they don't have orthokinematics. You should be performing a passive range of motion so they can achieve it. Okay, so now this is going to turn into from a measurement to now treatment. You're going to move them passively so they can regain these things. Same thing for active. If they're still lacking it, they don't have full active range of motion, let's go ahead and have them repeat that active range of motion a few times so they can start to regain strength and a control. Okay, so those could be considered as indications. There is also some contraindications, meaning that when you have these things, you're not supposed to be doing this. For example, movement itself might be contraindicated. Maybe the physician will specify that, okay, first week they are not allowed to get out of this knee mobilizer or shoulder sling. They have to stay in there and then they can't move. Okay, if they are on the specific protocol and the physician said they cannot do these things, then obviously that's a contraindication. You're not allowed to do any kind of passive range of motion. At the same time, maybe the fractured site, or maybe the patient just went through the rotator cuff repair surgery and those tendons that just got reattached are just too soft, too weak for it to be loaded just yet. Maybe you just have to give it a time to heal. Okay, that's also might be a good example of contraindication. If the tissue is not ready to be loaded, then please do not perform any passive range of motion. Active range of motion, because they're moving it more actively, our concern is more towards muscle fibers. It's obviously the same as here, but on top of that, muscle fibers are actively contracting and creating the motion. Are they ready for that? If this patient just strained the muscle, okay, performing the exercise actively is going to actually even stress that tissue more and maybe making the condition worse. Another good example is a significant lack of neuromuscular control, and NM is for neuromuscular. So maybe their shoulder is just so unstable that if they are to bring their shoulder up high here, it's going to dislocate. Okay, if that's the case, they're just too weak for them to perform active range of motion at that time. So you might need to do something in between, something known as active assisted range of motion, and we're going to talk a little bit more about that on Tuesday during the lecture.